Hello, my name is Michelle Kobayashi. I'm here today to talk to you about using the IPASS handoff format to improve handoff between EMS and emergency departments. By way of background, I am currently the Administrative Director of EMS and Emergency Community Operations at Hackensack University Medical Center, part of the Hackensack Meridian Health family. I'm here to talk about the experiences that we have and how we can do a better job of improving our handoff. By way of background, I began as an EMT when I was 16, riding in a volunteer ambulance in northern New Jersey. I then became a nurse, worked in the ICU and in the ER for over 10 years before taking over as a leader in the observation unit, after which I came back to EMS and currently work in a role as a director of EMS for Hackensack today. And I see the issues that we have in communicating between EMS and the ER and the steps that we need to do to take to improve that. Our objective today is to go over the details here. These are the disclosures for contact hours. You have to complete the post-test and score 80% or higher within 14 days of the course date. You have to complete and submit the evaluation form. There is no conflict of interest for any individual involved in this. I've been working with Tim Murphy from Robert Wood Johnson University Hospital, as well as Matt Strieger from Keaveney and Strieger, and also Katie Filippelli, also from Robert Wood Johnson University Hospital. No commercial support has been received from this offering. Our objectives today, first we're going to talk about liability and risks that are involved in the poor handoff techniques. We'll be looking at two legal cases that are published in the state of New Jersey to illustrate the points that we need to discuss. Then we're going to identify communication techniques and issues that can either improve or detract from our handoff. We'll talk about both IPASS and SBAR. SBAR has been very popular in hospital settings for many years now. We've been using it for over 20 years at Hackensack. And IPASS does have some advantages and is evidence-based. So we'll talk about why that's important. And then we're going to actually talk about the IPASS handoff tool itself. So first we'll discuss liability. Our first case, DiTarquino versus Jersey City, was brought to the courts and is published in 2002. We'll discuss the facts that are associated with this case. Now, please understand what the facts are that are recorded in the legal system are not necessarily the facts as they occurred in real life. So what we're going to be working with are the facts that are here. It is possible that other things happen that are different that weren't admitted to court. So we're going to use this just to illustrate the points, not to place blame or point fingers. This is an education opportunity, and this will just help us understand both the impact of a poor EMS handoff and also the impact of receiving EMS handoff poorly on the behalf of the ER provider. So in this first case, it happened in 1995, and in the statement of the case, the patient was assaulted by Jersey City Police Department. BLS was called to the police station, and while rendering care, the patient vomited. They brought the patient to Christ Hospital, left a copy of their run report, which indicated negative NV for no nausea or vomiting. The patient was assessed, treated, and then discharged to jail. 6 hours later, the patient had a seizure and was transported to Jersey City Medical Center, where they died from an epidural hematoma. What happened after this was a negligence claim for failing to record the vomiting on the run report on behalf of EMS. There was also an issue about a second run report being submitted where vomiting was entered on the report, but it wasn't on the original one. And they didn't write it as an addendum when they made the update. So it's important, and we all know this as ER providers, it's important to understand what we did and didn't know at different points during the decision-making process for care of the emergency patient. In this case, had the receiving emergency department at Christ Hospital known that the patient had vomited and potentially had a head injury, they may have treated the patient differently. And that's the question. Had the handoff completely provided all of the information, what happened prior to arrival, would the ER department had a better opportunity to treat this patient? The issue here was that there was no description of any verbal handoff between BLS and the ED staff, but we presume also because it wasn't in the run report that it wasn't discussed during the verbal handoff. So that's our example of when handoff doesn't completely convey all of the information prior to arrival in the emergency department. A second case, Lockhart versus Yeages from 2015, for a case that occurred in 2008. What happened was, at about 4:30 in the afternoon, the patient fell from a ladder while working 10 to 12 feet and landed on his chest on a cement floor. The patient complained of chest pain, difficulty breathing, but they were alert, had diminished lung sounds on the left, and a blood pressure of 180/62. ALS and BLS transported the patient to Level 1 Trauma Center, arrived around 5:21 p.m. At the time that this case occurred, the thinking was, we arrived within the golden hour to a Level 1 Trauma Center. This was the best thing that we could do for our patient. When they arrived to the ER, the patient was put in the hall, but the paramedic that was taking care of the patient said, this patient should be a trauma patient. And here there is an entire quote from the legal case that the paramedic testified that the patient was a trauma patient, and they gave reasons why. They're cold, pale, moist, vital signs were low. Fluids that were given on the way to the hospital didn't change vital signs. So during the paramedic's report, they start to explain why they felt that the patient should be classified as a trauma patient. And then the paramedic said, you've really got to get somebody over here to look at him. He's not going to do well. He's really sick. You've got to get somebody over here now. If they're not going to consider him a trauma now, hopefully, if someone comes over and looks at him, they will. So in this case, EMS was clearly communicating what they believed to be a trauma patient, and the ER staff didn't receive the information from the paramedic as the sense of urgency that was trying to be conveyed. Remember, this happened at about 4:30 in the afternoon. At 5:30, when the repeat vitals were done, blood pressure was now 106. Pulse ox was 98%, heart rate was 105. They gave fluid and triaged the patient as emergent. The family reported that the patient was cool, damp, and sweaty. At 5:50, the documentation reflects that the patient was diaphoretic with mid-sternal right-sided chest pain, hypoxemic with a pulse ox of 89% with oxygen via non-rebreather. So looking back at this case now, we can start to see that there's potentially traumatic changes that may indicate that this patient is bleeding or having other sorts of complications. At 5:55, the doctor evaluated the patient, didn't note any abnormal breathing, and ordered a chest x-ray. The chest x-ray wasn't entered until 7:25 in the evening, which is after change of shift. And at 7:50, the chest x-ray was read as no acute disease, but the patient still had a lot of pain. So they ordered a CAT scan and did find out that the H&H was low on the return from the lab results. At 8:40 p.m., the nurse noted that the lungs were clear, pulse ox was 96 on 100% oxygen. There was no mention of a blood pressure or heart rate, but in the legal documentation of this case, a scrap paper was identified with a blood pressure of 120/78 and a heart rate of 82 that was entered into medical record the next day. And this is important when we start talking about using the IPASS tool. Just remember that this scrap paper did make it into the record that the courts used to review this case. At 9:30 p.m., the patient grabbed his chest, his eyes rolled back, they started CPR, and he was pronounced at 10 o'clock. Looking back at the flow of the case from the time that the patient was injured at 4:30 in the afternoon to the time that he was pronounced at 10 o'clock. Looking back, it's easy for us to see that there were obvious signs that we should be looking for, but the handoff originally of the patient is the point that we want to make here, where the patient was not received necessarily from EMS in the way it was intended to be communicated, and that the patient was then put in the hallway, and then the sequela happened that we see in the rest of the case. The one thing that the court did note, that they were critical of the nurse because she stated when she testified that she spoke to EMS personnel but didn't remember any specifics of that conversation, which shows that the handoff in this case really wasn't part of the transition of care that we would hope that it would be. And that's something that we want to be able to change going forward. So some lessons from this case. The handoff between the ED and EMS was not formalized, not attentive, and not well documented. One thing that we notice here is something called anchoring bias, where when the first nurse saw that patient and put them in the hallway rather than activating a trauma response, it really kind of sends a message to the rest of the team that this is not a trauma patient, and the sense of urgency is definitely different when you put a patient in the hallway versus when you call them as a trauma activation. We also note that there was additional handoffs that could have but didn't raise red flags, such as the day to night shift transitions between the physician and nursing teams. The documentation is noted to be incomplete, where we see that the scrap paper was entered the day after, so what information did the team have when decision-making was being done real-time? And there was something that was noted here in this particular case where the paramedic may have spoken with the family member after the patient had died. And did they actually have a conversation with them saying, hey, we tried, something else went wrong here, which may have sparked a case to go to the legal system. So it's really important when we look at these things. Handoff, we know, Joint Commission has said this, handoff is one of the most risky things that we do as providers. Every time we give a handoff, we have a risk to lose information when we transition to the oncoming team. So our job as providers is to mitigate that risk. We want to reduce the opportunities for failed communication. So let's review the EMS basis for choosing hospital destinations, because some of this, from a perspective of attitude and mental preparation, really affect how we receive handoff on the hospital side. So understanding why EMS is coming to a particular hospital might help understand some of these dynamics. First of all, EMS is required to transport to the closest appropriate facility, appropriate being a really important word. For example, the specialty designation such as trauma, STEMI centers, stroke centers, pediatric specialties, and burn specialties will influence where EMS chooses to bring a patient. Also is important where a patient is already established their healthcare network, and what we look at continuity of care. When a patient's doctors are at a particular facility, they might not meet specialty criteria, but they would want to have continuity of care with their current healthcare team. They also might just prefer a facility. We may see them in the field and assess the patient and say, okay, what hospital would you like to go to? And they choose a particular hospital because of the reputation or because they like that hospital better, or don't like a particular hospital, they choose not to go there. What's really important to discuss is once a patient has arrived, they've arrived. EMTALA guides us in this. The EMTALA laws require us, once they're on our property and considered arrived, that they're a patient that we have to see, and we're bound by that. EMTALA, I have to say, is probably one of the most misquoted laws. That and HIPAA are probably two of the most misquoted things that healthcare providers like to discuss. And they like to bring up things that this is an EMTALA violation or that is an EMTALA violation. It's important to work with your compliance team to really understand how EMTALA applies to you. If the patient has arrived on your property, they've arrived. So obviously we cannot put them back in the ambulance and send them back down the road and have them evaluated at another hospital if you think it's more appropriate. So once they're here, they're here. And as an ER provider who worked the bedside, I know I've tried to wish away many a patient, and wishing them away won't make it true. But the thing is that as ER providers, it's a challenging environment. And sometimes our attitudes and perceptions really play into the handoff experience from the EMS provider to the ED provider. Sometimes we're angry. We're angry about the patients coming in to our ERs because we're overwhelmed and can't possibly see another patient that day. We're mad at EMS for bringing them to us. We're mad at administration for not supporting this. All of these things affect our emotions, which can play into how we receive handoff. Sometimes we're just hungry or uncomfortable because we have to use the restroom. We're just fatigued from a long 12-hour shift. And sometimes we experience anchoring bias as well, where something affects either a patient to either be up triaged or down triaged, or affects our perceptions of them. In New Jersey, we have a law called ATRA, which requires us to see patients that are intoxicated with alcohol, where in other parts of the country, they bring them to non-ER places, and that can be frustrating on top of everything else you have going on. All of these things can impact our ability to effectively receive handoff, and they're not going to go away. We're not going to stop experiencing these things. What we do have to do is use our emotional intelligence and recognize when we're feeling this way so we can filter for it while we try to receive our handoff. We have to be able to recognize that EMS is not bringing us patients because they want to upset us in any way. They're bringing us a patient because they're providing healthcare and we're providing healthcare, and they've come to our facility. What's important to think about, just in the back of our minds, in New Jersey alone, when patients don't come to your hospital, hospitals close. Hospitals are closing across the country. It's important that we receive our patients and do our best to take care of them and do our best to receive them with an open mind when we receive handoffs, so that we don't close out important information that can put us in a situation like what happened with the patient in Jersey City, or our second patient that fell from the ladder. So now let's talk about IPASS and SBAR, and I want to talk a little bit about how IPASS for EMS to ED handoff came to be through the experience at Hackensack. So two things happened. One thing was Hackensack has decided that they want to be a high reliability organization. So throughout the Hackensack Meridian Health Network, we received education on what it means to be a high reliability organization. And in this presentation, the decision was made that we're going to use IPASS as our format for handoff throughout the organization across all of our sites. So when we receive that information, of course, we start thinking about, well, how does that apply to me? So I started doing some research on how IPASS can be used in EMS and started finding out more about it working with the original IPASS team. The second thing that happened that really accelerated our decision to implement this program was we had a bad outcome as well. We ended up having to do an RCA on an event where a patient came in from the field. And I want to describe the case because I want to illustrate again how handoff really impacts how patients are transitioned between the pre-hospital to the ED environment. Our patient called 911 for difficulty breathing. Our EMS team responded. It happened to be our critical care team, so it was a nurse, paramedic, and EMT that responded to this patient's home. And on the way into the emergency department, they were giving treatments for a history of COPD. And they started to improve the patient's condition, but about halfway to the hospital, as they were getting to the hospital, the end tidal CO2 reading started to increase. And our patient started to retain CO2. And the nurse who was treating the patient had arrived to the emergency department, was on the place in the area where the ambulances park, and recognized that the patient needed positive pressure oxygenation. And even though we have CPAP on our ambulances, they were at the hospital. So it made sense to just go into the emergency department, get the BiPAP set up, and get the patient onto BiPAP. So they leave the ambulance, they go into the emergency department. She communicates this to the nurse, who then misunderstood what the request was and went to go get the computers to initiate the triage. The second call had to be made to respiratory. They brought the patient eventually a BiPAP machine, and the delay in receiving a patient into the ER and getting her on the positive pressure ventilation made the difference in the patient then going into cardiac arrest. The patient went into cardiac arrest before the BiPAP could be started, and the patient expired in the emergency department. So this case was reported to the state. And when we did the RCA squared on this, we looked at what went wrong. And a couple of things came up, but one of them was the handoff. The fact that the nurse that received the information from the nurse in the field didn't recognize the sense of urgency that was trying to be communicated. We missed that opportunity to really communicate bottom line up front, what is wrong with this patient, which then resulted in a delay. And there were other factors, of course, that played into what happened with this patient. And there were other outcomes that we looked at, but the handoff piece was really critical. So we said, all right, we need to standardize this. We need to really make sure that our EMS teams are communicating effectively with our ED teams. And so we started to work on building the IPASS tool. Now, we had been using SBAR for years in the emergency department. The thing about IPASS, and IPASS is evidence-based in New Jersey. New Jersey ENA did do a journal review of the literature that supports IPASS, and it was found that, yes, IPASS is appropriate to our care settings. When you look at the IPASS literature, 2/3 of sentinel events are caused by communication and handoff failures. Studies show that the IPASS, just the format itself, reduces medical errors by 23% and injuries associated with them by 30%. Those are big numbers. That's close to 1 in 4 medical errors going away, and about 1/3 of them not having injuries associated with them. This is a major patient safety initiative that we have an opportunity to take on as ED providers. In the IPASS studies, when they observed the handoff process pre and post implementation, there was no increase in the amount of time it took to actually do the handoff, because all IPASS does is take the information we're communicating and organize it. The reason IPASS came about, if you go into the literature and review, when medical residents were in their residency programs, once upon a time they had very long shifts, and they said, oh, this is terrible, bad things are happening to patients because of the fatigue associated with very long shifts. We need to shorten the shift length. And what that did was increase the amount of handoffs that were occurring. So we traded one problem for another. We got rid of fatigue, and we started having failure to communicate across shifts, and that was causing injuries to patients in a different way. The IPASS study team looked at this interaction between medical residents and found that there was an opportunity, just by standardizing communication, to avoid as many errors as possible. And here they found 23% of the errors and then 1/3 of them not having injuries. So what we've done now is started looking at how do we implement this in our care setting. SBAR, what we found, if you look at the literature, is used for situational episodic communication. It's intended to be brief, and it works well for things like phone calls about critical events or non-complicated patients. When you start looking about the complexity and acuity of patients coming in from the pre-hospital environment, IPASS, as an evidence-based tool, is superior to SBAR in that way. So a couple barriers we want to just make sure that we're aware of when we talk about effective handoff is looking at a couple different things here. One is the physical setting. I know many ERs across the country are physically challenged either in how many patients they're holding or just the physical layout itself. There's not always a nice, quiet, private place to be able to have a handoff where you can focus and concentrate on what's being said to you. Again, it's not something that we're going to be able to eliminate, but using emotional intelligence, we can be aware of it and filter for it while we're trying to receive our handoff. If we have an opportunity to make it more quiet, for example, in a trauma timeout prior to handoff, or if we're able to step out of a hallway or out of a high traffic setting to improve our handoff, those are things that we can do to mitigate that risk. Social settings also impact this. I find that when I, as an EMT, arrive to a hospital where I know people, I walk into the ER and I start talking to the nurses that I know, they're more open to receive handoff from me than nurses that don't know me at all. That's just a function of having an established relationship provider to provider. So those social settings can have an impact on handoff. They can also have a negative impact on handoff. If I have a poor relationship with somebody and I walk in, they might not want to listen to me just because they don't like me. Again, that impacts handoff. Our emotions, as we discussed earlier, can really play into handoff. If we're mad about something, we might be thinking other things. We could be emotionally invested in something outside of the work environment that's also impacting this. That might not go away. Just to be aware of it and how it impacts our handoff is the key. Communication issues, sometimes the sheer noise. Sometimes accents, if somebody has English as a second language and has an accent that they're speaking with. We've had an incident recently of SIRS versus SARS, and we were at a communication error related to that, related to somebody's ability to speak and enunciate the difference. Time pressure, which is probably one of the most important things in our ER environment. I know I can say that I've been running down the hallway with my pain medication to medicate my patient who's been waiting patiently, or maybe not so patiently, for me to medicate them, only to find out that I have a EMS handoff coming. It's very hard for me to stop and listen and be able to get back to what I was doing to care for that other patient. This is a very common thing we deal with every day in ER nursing. All of these things can have a negative impact on how we receive handoff. It's our job, knowing that handoff is a critical piece of care for a patient. How do we look at these things and account for them and filter for them so that we do the best job that we can? So again, some key things that we can try to do. Try to choose a location that's not hectic whenever possible. Limit interruptions and distractions so that when you receive handoff, it's a continuous, crisp, clean handoff. Be self-aware regarding emotions and anchoring bias. And verify received information. We know that we use readback or receipt back to our critical results and to physicians when doing telephone orders. We know that this is a best practice. Using it in the handoff tool is another way for us to make sure we're not missing critical pieces of information. This is something we do every day. It's a skill that we have, and it's a skill that we can use in this environment. So our goal by implementing the IPASS tool is to improve communication, improve patient safety, reduce medical errors, improve customer service and family considerations. Think for a minute when you're the patient on the stretcher and you've told something to your EMS provider and you want to make sure the ER nurse receives it, and you see a crisp handoff where the ER provider receives that information from the EMS provider. Trust builds between you as the patient and both of those teams when you feel that that's actually been communicated team to team. It's the same philosophy that we use in bedside report between shift to shift. This, it's really important to understand, has no negative impact on our workflow. When we start talking about the tool, I'm going to show you how all this does is rearrange the information that we're receiving today, and it's actually going to have an improvement. If we can receive crisp handoff, then we'll actually be able to limit the amount of time that we're spending to receive handoff and hopefully improve the quality of that handoff. So let's start by looking at the tool. So this tool was developed at Hackensack University Medical Center. It is copywritten because we are working on collecting data on how we use this tool and if it is making a difference. We've got some pre-data and we're looking to do some post-data once the education has been rolled out. It is available if you want to use this tool in your area. If you want the permissions to put your watermark or logo on it, you're welcome to do that. You just have to reach out to me and let me know, and then we can grant those permissions. So you're definitely welcome to do that. I want this tool to be shared openly as much as possible because I think this is the right thing to do for patients. Okay, Looking at the I in IPASS, the first step of the tool is to go over illness severity. It's the bottom line up front, or BLUF. For Hackensack, we have 5 areas of patient care that we use for resuscitation. We put them right into resuscitation rooms. We have teams respond, and they focus on these cases just to get an immediate jump start. As we saw in the one case from Hackensack with the RCA, the arrival process for patients, especially in the world of electronic medical records, is a much slower process than it used to be. You can't do anything without registering your patient, getting them into Epic, then getting your medications profiled. It's not like we can just start treatments like we used to. We have to be able to access them in the system. And so our arrival process is a lot more complex than it used to be. So understand what we're dealing with up front and being able to respond quickly to those patients that need us most. Those are the ones that we call out here. We intentionally did not use checkboxes on this form because you could checkbox 1,000 different things and the piece of paper would go on forever. So under other is where everything that's not a chest pain or STEMI patient, stroke patient, sepsis or oncology patient, trauma patient or cardiac arrest, everything else goes in that box. And it's just a very high level of what type of patient are we dealing with. It's the what do you got when you walk through the ER doors and you're hitting that first nurse that wants to know what's going on. What do you got? I got a chest pain patient. It just gives them a sense of what they're dealing with. The second piece in this area is really important. It's the date and time that the patient arrived to the ER, the agency that brought them, and the names of the EMS providers that brought them in. This is important from a provider safety perspective. We receive patients that in the middle of the care, we recognize that the patient has a communicable disease, where we want to call the EMS provider back and notify them, hey, you might actually need to be seen and treated because this patient has TB. Or this patient might have lost their personal belongings and you need to find out where their dentures are or their hearing aids or any of those things. It's really important that we have a way to make sure we connect back to EMS if we have questions. This is true for any handoff. All of the handoff tools out there are given opportunity to ask questions and get back, but when EMS leaves the ER, your opportunity doesn't have to be over. So we communicate that information here. So this is the illness severity. We also have in EMS a red, yellow, green triage system. It just gives us a sense from EMS's perspective, how sick is this patient? The second letter in the IPASS, the P, stands for patient summary. This is the bulk of the handoff. This is what you typically receive in report. It focuses on demographics, chief complaint, history of the present illness, assessment findings, including vital signs. Again, we left this free form because different patient conditions require different things. In pediatrics, we might not get a blood pressure. In an adult intubated patient, we might get an end-tidal CO2. So if we checkbox all these sections, what we found is that it limits what EMS is able to capture in the tool. In this area, we capture the patient's name, date of birth and age, gender. We capture address. We don't typically give address during the handoff itself, but we need it to write our chart. And in order to do that, and sometimes to verify identity when you're doing registration early in the ER arrival process, we capture chief complaint from the patient's perspective. We also capture the history of the present illness to understand what brought them to the 911 system. Our assessment as EMS providers, including injuries and signs and symptoms, and then a place for us to record vitals. Under patient summary, you see the beginning of a missed handoff. When we worked with our trauma team, they had required us to give a missed handoff. But rather than have multiple different tools for EMS to use, we realized we were able to incorporate everything into one tool. What we found is that if we just did missed handoff, we were missing important things like the patient's demographics, what their chief complaint was that we use for other patients within our system. What we're able to do here is make sure we don't leave out any of the important missed portions of a handoff. So we're able to incorporate both. The next section of the tool is the actions or treatment under the MIST mnemonic. In EMS, the interventions that we give, we realize this is where we give meds. So this is where it made sense for us to put our allergies. If we're giving aspirin for a chest pain patient, it's important to, at that point, make sure we remember to check, do they have an allergy to aspirin? So recording that information next to the interventions made sense when we worked with this with the EMS providers in the field. We also capture treatment that we're unable to give. There are times in the field where patients just don't fit the standard of care. They don't fit the protocol. For example, you might have a patient where you can't put a hard collar on, and you might have to use a towel roll to do your best to stabilize a patient for whatever reason. Maybe they have something protruding from their neck, and you have to do some sort of C-spine stabilization. We want to tell you that we didn't just forget to do it. We intentionally chose not to do it, and here's why. And that's an important part of our handoff. Situational awareness is the next piece of the IPASS mnemonic. It's the first S. Under situational awareness, this is where we talk about the things that we might pull the nurse aside to say, here's something else you need to know about this patient. This is typically the things that we don't share in front of the patient. For example, if there was a death in the same passenger compartment, that's sometimes used to determine whether somebody should be a trauma activation or not. We don't necessarily want to share that in front of the patient because that might be information they don't know yet, and that might not be the right time to bring that information to them. If the patient is a sexual assault patient, if this is a child or elder protective services patient, or there's an important family dynamic that needs to be discussed. These are things that you might not want to discuss in front of the patient, but it's important that the next healthcare provider understand that's what goes in this box. When we worked on developing this tool, we had a multidisciplinary team at the table that included ER nurses from both adult and peds, as well as EMS providers. And the one thing the ED providers told us was, if you as EMS could get us the cell phone number of a family member and get that to us when you bring us the patient, that would really be helpful. A lot of times family follows EMS and they can't follow through intersections, so they lag behind when they arrive to the hospital. And sometimes early decisions need to be done in healthcare, and we don't necessarily know maybe if the patient has an allergy to something or something pops up in the electronic health record that says, hey, there's information here that's different. The patient can't tell us, maybe they're unconscious. We need to talk to that family member. We need that early. And they said, can you get that onto this form? And situational awareness seemed to be the best place to put that so that we communicate that to the ED. So that's where we put that information. The last part of IPASS, this last S, summary, this is the responsibility of the ED provider. This is what makes IPASS effective. The ED provider reads back or summarizes back the key points of the handoff. This gives us an opportunity, one, to make sure EMS got the key information across. And it also gives EMS an opportunity to speak up and say, don't forget, I also told you this. It might be something that's really important as part of the handoff, and we want to make sure that it gets across to the ED team. This allows us to verify that information was received and the important elements were communicated. This is what makes IPASS different from other handoff tools like SBAR, because it's not a passive process. It's an active interaction between the sender of the information and the receiver of the information. It allows for both sides to ask questions and to be able to clarify the information that's being shared between the two teams. This is the back of the form. It captures medications and history, and at the bottom section, we have a space for critical care. For interfacility transfers, the transport nurses capture lab values and other information like vent settings that can be noted here. For EMS, our guidance has been that they can use it for other additional sets of vital signs or any other information that doesn't fit on the front side of the form. So just make sure when you're receiving handoff, if you're looking at the form after the handoff's complete, or if you're the second or third nurse looking at the form, just double check to make sure that the information on the back is captured. It's actually interesting to note that the original design of the form was a little bit different, and when the frontline providers were using it, they asked, hey, Michelle, can you move the medications and history columns next to each other rather than top to bottom? And I remember this from being a triage nurse, that the medication history helped me to elicit a medical history. So we were able to make that change, and it seems to be working well for the teams that are in the field. I think it's important to keep in mind that this is a tool that was done in collaboration with ER nurses, EMS providers, ER leadership, EMS leadership, everybody at the table working together to figure out a handoff that'll make sense for both the EMS providers and the ED nurses that are receiving the information. The next thing we're going to do is talk about two scenarios to see how IPASS works in action. We'll go through a couple of key pieces of information on a patient that is actually a patient that we took as a de-identified case from EMS. So we actually backwards worked our information into a tool to make sure it would make sense. And then we actually used it prospectively to see and test it in the field. I can tell you that I personally use this tool in the field as an EMS provider, as an EMT, and I find it very helpful to be able to organize the information. So the one thing that's really important to note is that using the tool allows you to capture information in any format at which it hits you, right? Sometimes information doesn't come to you in a logical pathway, and it comes with you in multiple different directions. We can capture it from many angles and then give it back to somebody in a standardized format. One thing that we talked about with our ER providers is that sometimes EMS is coming in with a very challenging case where they may not have written anything down. One thing that the ED provider can do is take a blank IPASS form. We actually stock these in our ER so EMS can come pick them up whenever they need them so that we can support the EMS community in using it. The ED nurse can take a blank IPASS note and receive handoff in an organized format. So let's look at two scenarios using the IPASS tool from the EMS perspective. In the first case, this is an ALS patient that did not have ALS available. This is an 8-year-old female with seizures. BLS finds Mary Smith, date of birth 10/23/2009, supine on the couch and unconscious. She's in status epilepticus with doll's eyes movement. The father relates 2 seizures lasting over 1 minute. She has a history of seizures and she's on Keppra. She's got no known allergies. First set of vitals, they were able to get a heart rate of 160, pulse ox of 90 on room air, respiratory rate of 10, Glasgow is 4-1 unable, BP is unable to obtain. Patient is positioned on the left side to prevent aspiration until seizure ended, with oxygen at 15 liters via non-rebreather. They put the patient on the stretcher, transported the patient to the closest ped center for treatment, and canceled ALS due to proximity. They repeated vitals, heart rate of 144, pulse ox of 92 on 15 liters, respiratory rate of 16, Glasgow again, 4-1 unable, BP unable to obtain, temp 102 axillary. Further assessment, pupils are equal and reactive, 3 millimeters, cap refill is less than 2 seconds. They gave ice packs to the axilla for fever. On the way to the hospital, the patient had another seizure where they placed her in left lateral position to protect the airway and then handed off on arrival to the nurse using the IPASS format. So you can see all of this information comes to the EMS provider kind of in random form, which the EMS provider is then able to capture on the IPASS tool. Now, when we give this class to EMS providers, and when I speak with them about this, about using this tool, and I ask them, are they currently using a pad to write notes on? Inevitably, the answer is yes. At Hackensack, I see them using, folded in half forms. I see them using little memo pads. In my volunteer agency, we have little yellow pads that have very similar information. The truth is that we're still writing things down. Even in the world of the ability to do real-time charting on iPads and computers, we're still writing. Handwriting is still faster to be able to capture information. It's easier to make corrections with if you have to, backspace and then put your cursor in the right place. In the fast-paced environment of the pre-hospital space, we capture information very quickly. Same thing like in the ER. So we're all still taking notes. The IPASS tool is just a different notepad. All the same information is being captured. In fact, hopefully more information is being captured and the correct information is being captured because the tool is structured to capture what's needed in handoff. So in this case, if you look at the tool itself, when you read the tool from top to bottom, the goal is to be able to give a very crisp EMS handoff. The one thing I find when I'm watching EMS to ED handoff is that ER nurses get frustrated because the EMS provider comes in, and I am guilty of this. When I went back into EMS trying to give a report to an ER nurse, I was terrible. I'm still actually not that great without my IPASS tool. And it's the patient, well, when we got to the house, the police were there, and we start trying to explain what's going on. We're kind of all over the place. Now, some EMTs and paramedics are really good at this. They're very crisp. They're able to give great reports. They do this day in and day out, but not every EMS provider is like this. And what happens is, as ER nurses, we get frustrated, we stop listening, we start talking directly to the patient. And what happens is we lose the information that the EMS provider collected on scene. And sometimes there's information that the patient doesn't know, again, with our situational awareness or other context, that we're missing in our handoff. We're losing pieces, or the patient may forget to tell us something, or the patient might not be a great historian. So all of these things can happen that will negatively impact our handoff. Now when I go and I give report as an EMT to an ER nurse, I'm able to give a very crisp handoff. And this is what it sounds like. So I'm coming in with a status epilepticus seizure patient. My name's Michelle Kobayashi. I'm an EMT with Hackensack EMS. This is Mary Smith. She's an 8-year-old female. She comes in complaining of seizures. At home, she had seizures lasting greater than a minute, times 2 as per her father. When we got there, she was unresponsive with doll's eyes movements. Pupils were equally reactive at 3 millimeters. Cap refills less than 2. At 16:14, she had another seizure lasting 2 minutes. First set of vitals were okay. Second set of vitals, we found that her temperature was 102. So we put ice packs to her axilla. We put her on some oxygen. We kept her on her left side just to keep her airway clear. She's got no known allergies. She's got, we're not able to get a blood pressure because of her seizure activity, and we canceled ALS due to our proximity. Here's the father's information. She's got a history of seizures, and she is on Keppra. That's the EMS handoff. It's very crisp. When you read from top to bottom on the form, you capture all the information, you don't skip anything. Anything that's important gets communicated. And at the end, we just take down the name of the nurse that we gave handoff to, and we'll talk about why we do that in just a moment. So let's look at a second scenario here. This is a back injury patient coming in BLS. This is an 82-year-old male who fell and struck his head. BLS finds Bob Jones, date of birth 8/30/35, sitting upright in bed, A&O times 3. He experienced a fall while standing up from the toilet. He felt dizzy when he stood up. He denies loss of consciousness and head and neck pain. He complains of right lower back pain. He's got a history of diabetes, high blood pressure, and chronic knee pain. He's on a bunch of medications: Apidra, Crestor, Eliquis, Glimepiride, Glumetza, Lantus, Metformin, Metoprolol, Rosuvastatin, Tamsulosin, and Telmisartan. He's allergic to no medications. Vital signs: a heart rate is 92, blood pressure 124/52, pulse ox of 98 on room air, respiratory of 18 with normal effort. Cincinnati was negative, Glasgow is 15. He's A&O times 3. His motor is weak, pupils are equal and reactive. Cap refills less than 2 seconds, skin is pink, warm, and dry, known signs and symptoms of trauma or injury. He was assisted to the stair chair by stand and pivot by EMS, so they weren't able to assess his gait. He was carried out of the home and moved to stretcher by stand and pivot again, secured with straps, and placed in the ambulance. Repeat vital signs were a heart rate of 86, pulse ox is 99% on room air, respiratory rate is 18 with normal effort. Cincinnati was negative, Glasgow 15. They handed off to the RN at the ER using the IPASS format. So here's what the IPASS tool looks like for this patient. So notice if you look on the medication side, Eliquis is circled. So they're marking this as a trauma patient. So BLS is assessing this patient. They're concerned because this patient is on blood thinners. So in this first illness severity section, they're calling that out as important. Now, they might not understand how that fits into the overall healthcare system or how your trauma center activates trauma and if this is one of the criteria. But this is something that we all know we look out for. So when they first come in, they're going to give you illness severity. You know, we upgraded this patient to yellow, it's head and back pain, and the patient's on blood thinners. And they're going to remember to tell you that right up front. So when you're like, okay, well, what are you bringing us? You know, what do you got? I got a trauma patient on blood thinners. So you're going to start now thinking through that. Now they're giving you anchoring bias. They're taking that information and saying, we think this is important. We want you to pay attention to it. So it goes in this illness severity section. But just in case they forget to talk about it there, it's also circled in the medication section, which allows them to remember to make sure that very important piece of information gets communicated in handoff. So the handoff would sound something like this. This is Bob Jones. He's an 82-year-old male. He has back pain on the right lower side, head and neck pain. He fell from standing after using the toilet. He does note that he has dizziness, but he says he did not lose consciousness. He's A&O times 3, Glasgow is 15. Pupils are equal and reactive at 3 millimeters. Cincinnati is negative. His motor is weak. Cap refills less than 2. Skin is pink, warm, and dry. He has no signs and symptoms of trauma or injury. Vital signs were stable. We did put C-spine precautions in place. He does not have any allergies. His wife's on the way. This is her phone number. He's on a slew of medications. Again, he is on blood thinners. He takes Eliquis. He's got a history of diabetes, hypertension, high cholesterol, and chronic knee pain. As you can see, an IPASS handoff is much more crisp than everybody trying to figure out what information needs to be communicated and try to remember things. It gets rid of the ums and the ahs and the wait, let me explain the family piece of this. Everything has its place. And by giving a crisp handoff, it helps the ER nurse to receive the information in a timely way that's crisp, and they're able to move on to the next thing that you have to do. So, really important just for the objectives to review our conclusions, and we'll talk about our next steps. There are legal implications for poor communication and missed handoff. That's really important. I know that we talk about like, oh, if you don't document properly, you could, get in trouble for it. What does that trouble look like? Well, our two cases in the beginning of this discussion show us what trouble looks like in the context of poor handoff. It's important that you document your handoff in your chart. It's important that people know that handoff did occur, that it wasn't missed, and who was participating in that handoff. If there was a problem in handoff, if the handoff couldn't be completed for whatever reason, that should all be communicated so that we know what happened. Handoff requires active communication. Just putting information out there and hoping somebody receives it is not a great way to make sure that you validate that the key piece of information got to the other side. This is what makes IPASS different. The nurse summarizing back and saying, oh, so you're saying you have an 8-year-old female with a history of seizures, she's on Keppra, she's having seizures at home, dad's on his way, she had another seizure on the way in, she's got a high fever. Those are the key pieces. When the nurse repeats that back to the EMS provider, the EMS provider can say, yes, those are the important things. Everybody has an opportunity to ask questions, second chance to make sure you don't skip anything. Having that closed loop communication is what makes the difference in getting important information from the sender to the receiver. Standardizing the process reduces sentinel events and patient risk. It is evidence-based. There are studies that show that this tool can reduce those risks for our patients. So it's important for patient safety. So next steps. So for you to go back to your teams and say, how do we do this? How could we make this part of our everyday? That would be something that, we would hope everybody would be able to do after taking this class. So remember I said that we do make the IPASS tool available. We can send you the base document with permission to, if you would like to put your watermark on it, we have our watermark on it. If you want to market that to your local EMS providers and partnership to bring them in as part of your healthcare system, you're welcome to do that. If you need to work with your team on how to get them to understand it, we're always able to help, so you can reach out for guidance from us. Some of the things we did at Hackensack with this was training the nurses and the EMS providers using the same slide deck. This is the same information that EMS and nursing is getting. By going over the same information with everybody, it puts everybody on the same page. So that is a great next step. If you want to engage your EMS providers in your community using the education here, we can work with you on that. That's what we're doing at BIAS. Another thing we're doing by educating the nurses on how to use this tool, sometimes EMS comes in with really, really horrific cases, right? All hands on the patient is really sick, traumatic cardiac arrest, regular medical cardiac arrest, sometimes you just have really, really sick patients and nobody's writing anything. The ER nurse can then guide the handoff. We keep blank tools in our ER so that EMS can take them with them if they need them so they can replenish their stock. Any ER nurse can grab a blank IPASS tool and receive the information and guide the conversation, even if you're not writing. We find that, we still write things down. We're still writing things down on a scrap paper so we can go back and make sure we chart it. You're welcome as an ER provider, if there's no tool to receive, to take the information in order and prompt the EMS provider to make sure they don't skip anything. This will help them, especially in those really challenging cases. So that's how we can use the tool. Another important thing, go back to our cases in the early part of the lecture where we talked about that scrap paper making it into the legal record. I get a lot of questions when I teach this class about, well, what do we do with the copy of the report? I can tell you that I take a photocopy when I give IPASS handoff. I leave the original because I feel like my handwriting is easier to read in the original than it is in the copy, because I'm going to scan it anyway into my medical records. So I make a photocopy at the ER, I take a copy back to quarters, I write my EMS chart, and I scan and attach a copy. The question is this tool a part of the medical record? And the answer, I think, is whether you want it to be or not, it could become one. So you can either choose to include it and have all the information should a case go to litigation or go to review. The lawyers are going to find copies of this. I personally would rather have the copy up front and be able to review the information than have to get it from somebody else's attorney handed back to me. That decision is based on what your organization chooses to do. Medical records and health information have very specific guidelines on what they do and don't include as part of the medical record. But just know that when you complete a tool like this, there is a chance that it could get scanned and attached as part of the EMS record to a hospital medical record. So what I encourage EMS to do is include it in their EMS record as part of what handoff had at the time that the patient was handed off. As information comes to light, sometimes the question is, did EMS know that? Between our chart and our handoff tool, we're able to look and say, what did EMS know at the time? And that really helps with our clinical decision making. The last question that I get a lot too is, what does the signature mean? And I get this on a lot of EMS forms. What are we signing? What are we liable for? I don't want to be, like my license is at risk. We get a lot of those questions. At the bottom, in the summary section of the tool, it's not a signature. It's just a place to record the name of the nurse or the ER provider. It could be an APP or a physician that receives handoff. The name of the person receiving handoff. And two reasons. One, we want to be able to record that we gave handoff to this ER provider. So we put that in the EMS record. But there's a second, more practical reason for the ED staff. In many EDs, now when you arrive a patient, they arrive to one provider who screens the patient and may or may not do a triage. The patient may then go to triage, or they may go directly back to a patient bed in the ED. So before the patient's even seen by the physician, they may have actually been in contact with 2 to 3 nurses or other providers, in their early part of their arrival in the ER. Sometimes that patient arrives to your area. So the scenario that I'm familiar with is I'm in a room medicating a patient and they're looking for me and can't find me. And I come out and I check the computer because I need to update an order or something or document something. I see that there's a new patient in my trackboard. And I see that I have no idea who this patient is, but they're assigned to me. And now I want to find out what's going on. Well, if the IPASS tool is used as a leave behind by EMS and it's filled out by either the EMS provider or the initial receiving nurse with the name of that nurse at the bottom, now I can go back and say, hey, I have a question about this patient. I don't understand what happened, or I talked to the patient and I looked at the tool and did EMS tell you about whatever? And if it becomes really important, at the top of the tool, I can actually call EMS and say, hey, I've got a question. So by providing this information, it just connects us all throughout the handoff process so that important information doesn't get omitted as we begin to care for our patient. So there's no signature required there. Just printing the name of the nurse is sufficient. It's just important to understand who is involved in the handoff of this patient in case there's gaps that we need to close.